What's going on, guys? You're watching medvidsmadesimple. I made this video because one of my subscribers has asked me to do so. If you're new to my channel, make sure to subscribe and press the bell icon nearby so that you'll not miss out any of my videos. This video is about beta blockers. Let's talk about some physiology of beta receptors before getting into the video. The beta receptors are of three main types: beta 1 receptor, beta 2 receptor, beta 3 receptor. Beta 1 receptor is mainly present in heart and in the juxtaglomerular cells of the kidneys. Beta 2 receptors are mainly present in bronchi, liver, uterus, and blood vessels. Beta 3 receptor is mainly present in the adipocytes. Let's talk about the classification of beta blockers. Beta blockers are classified as non-selective beta blockers, which act on both beta 1 as well as beta 2 receptors and block them. The non-selective beta blockers are further subdivided or classified um, based on uh, based on if they have intrinsic sympathomimetic activity or not. So they are further classified as the drugs which does not have intrinsic sympathomimetic activity. This includes drugs such as propranolol, sotalol, timolol. There are certain drugs which has intrinsic sympathomimetic activity. What is this? This actually means that these drugs has a property known as partial agonist activity, which means these drugs are actually beta blockers. But in addition to being beta blockers, these drugs have some intrinsic capacity to act as an agonist to some extent. But the beta blocking capacity of these drugs will be very much more compared to the capacity to act as agonist, and that's why they're regarded as beta blockers, but with intrinsic sympathomimetic activity. This group includes pindolol and some other drugs. There are certain drugs which are in addition to being non-selective beta blockers, they can also block the alpha receptors. So they have the capacity to block alpha receptor as well as beta 1 and beta 2 receptors. This group includes labetalol and carvedilol. Now, these drugs are non-selective beta blockers, which means they block the beta 1 as well as beta 2 receptor present in the body. Now, there are certain drugs which are more selective to the beta 1 receptors. So, where are the beta 1 receptors present? They're mainly present in the heart, right? So, if you want more specific action on the heart, we'll prefer this group of drugs which are known as cardioselective beta blockers, which mainly blocks the beta 1 receptors present in the heart. This group includes drugs such as metoprolol, atenolol, acebutolol, bisoprolol, esmolol, bitoxolol, and nebivolol. Acebutolol is one drug which also has intrinsic sympathomimetic activity like pindolol. Actions: beta blockers act on heart and on the juxtaglomerular cells of the kidney, and they block the beta 1 receptors present in them. So, by blocking the beta 1 receptor present in the heart, they carry various actions like decreasing the heart rate, decreasing the force of contraction, and decreasing the cardiac output. All these actions sums up to cause various changes like decrease in blood pressure, control of heart rate, etc., making them suitable to be used in conditions like hypertension and arrhythmias, etc. These actions also makes them suitable to be used in non-cardiovascular disease conditions like anxiety. Now, by acting on the beta 1 receptors present on the juxtaglomerular cells of the kidney, what they actually do is that they decrease the renin secretion. By decreasing the renin secretion, they inhibit the renin angiotensin aldosterone system, and by doing so, they further decrease the blood pressure. Beta blockers acts on the beta 2 receptors present in the blood vessels, and they cause various changes. Now, if we're talking about that, there's a phenomenon known as re-reversal of vasomotor reversal of Dale. I'm not going to mention about this in this video. If you guys want a detailed explanation on this topic, make sure to comment below. I'll make a detailed explanation on that and in my blog page, and I'll link it in the comment section. Upon stimulation of beta 2 receptors, normally there will be vasodilatation and decrease in BP. But when we give a non-selective beta blocker like propranolol, what happens is there will be blockage of the beta 2 receptors present in the blood vessels, so vasodilatation cannot take place. This leads to an initial increase in blood pressure because vasodilatation cannot take place. But the blood vessels will undergo adaptation to these changes, and finally there will be decrease in blood pressure. It's okay if you guys can't understand this thing. It's enough to understand. It's enough to understand that beta blockers cause a decrease in blood pressure. In addition to that, they also block the beta 1 receptors present in the kidney, as I mentioned earlier. By blocking the beta 1 receptors present in the kidneys, they decrease the renin secretion and decrease the renin angiotensin aldosterone system, and by doing so, they cause a further decrease in blood pressure. So this adds up to the decrease in blood pressure which is obtained by blocking the beta 2 receptor present in the blood vessels. Their action on bronchi. Physiologically, upon stimulation of the beta 2 receptors, there will be bronchodilation. So when we give a non-selective beta blockers such as propranolol, it will block the beta 2 receptors present in the bronchi, and so bronchodilation cannot take place. This will lead to worse or even severe adverse effects especially in asthmatic patients. So these patients can develop severe bronchoconstriction and this can lead to life-threatening complications. So that's why non-selective beta blockers are usually contraindicated in asthmatic patients. Upon giving some beta blockers topically over the eye, what they actually do is that they decrease the aqueous humor secretion. So by doing so, they lower the or decrease the intraocular pressure. So this action makes these drugs suitable to be used in various types of glaucoma, especially in open-angle glaucoma. Metabolic effects. These effects become significant when these drugs are given on a long-term basis. The metabolic effects of beta blockers are mainly that they block lipolysis and they can also block glycogenolysis in heart, muscles, and in liver. They can also cause an increase in plasma triglyceride level and an increase in LDL HDL ratio. So they cause an increase in the bad cholesterol and they decrease the good cholesterol on a long-term basis. Pharmacokinetics. Let's consider propranolol, and first let's talk about the pharmacokinetics of propranolol. Propranolol is well absorbed orally and it undergoes high amount of first pass metabolism in the liver. So after that, propranolol is lipophilic drug, so it can easily cross the blood-brain barrier and it can carry out various side effects associated with it, on which we'll be talking about later in this video. And propranolol, if taken along with food, um, if taken along with food, can escape from the first pass metabolism to some more extent. So that makes that increases the half-life of propranolol to some extent. That's why it's always advised to take propranolol along with food. The metabolites of propranolol are excreted by the kidneys in the urine. Propranolol is about 90% of the time plasma protein bound. Some drugs in the beta blockers have a property known as membrane stabilizing action. Now, this is a very significant property, and if the drugs which has these properties, such as propranolol, oxprenolol, and acebutolol, are suitable antiarrhythmic drugs. The membrane stabilizing action of these drugs are become very apparent at higher doses compared to the normal doses of these drugs given for other conditions. So the drugs such as atenolol, bisoprolol, celiprolol, and sotalol are lipid insoluble. Now, how is this even significant? When these drugs are lipid insoluble, what's the benefit of this is that they cannot cross the blood-brain barrier. So if these drugs are lipid insoluble and they cannot cross the blood-brain barrier, there will be comparatively lesser side effects. And since they are lipid insoluble, they do not undergo first pass metabolism to a greater extent, which means the half-life of these drugs are comparatively more compared to the drugs such as propranolol, which are lipophilic drugs. Now, this is a significant property. So since these drugs have longer half-life, the frequency of administration of this drug or frequency of taking this drug is comparatively less compared to the lipophilic drugs like propranolol. Certain drugs, as I mentioned in the classification of the beta blockers, has a partial agonist action. So what does this actually mean, and which drugs has these properties? The non-selective beta blockers and few of the cardioselective beta blockers, which has intrinsic sympathomimetic action, are actually the drugs which has partial agonist action. I've already talked about this in a small detail while talking about the classification of these drugs, but here I'm going to explain about that in a bit more detail. So what's actually the partial agonist action is that the drugs like pindolol, celiprolol, and acebutolol are actually beta blockers. Now that's okay. In addition to that, these drugs also have the tendency to stimulate some of the beta receptors. So don't take this as like don't get confused with this concept actually. They are actually beta blockers. So they're gonna block the receptors. In addition to that, they can also stimulate the beta receptors to a little extent. So what is actually taking place in a more amount is that is the beta blocking property of these drugs um, compared to the agonist action of these drugs. So they are actually beta blockers, considered as beta blockers. Now there are certain benefits associated with these drugs. This includes withdrawal of these drugs rarely exacerbates hypertension or angina. Now, this is not the case this is not the case with drugs like propranolol. In the case of drugs like propranolol, if you suddenly withdraw giving these drugs to patients, what happens is there will be exacerbation of hypertension, which is known as rebound hypertension, and there can be sudden increase in angina. But this is not the case with drugs which has intrinsic sympathomimetic action, like pindolol, celiprolol, and acebutolol. These drugs do not affect the lipid profile to a greater extent, so that's beneficial. But these drugs are not so effective in migraine and for secondary prophylaxis of myocardial infarction. So for these purposes, these drugs are generally not preferred. Let's talk about the uses. The most common use of beta blockers is in hypertension. It can also be used in stable variety of angina pectoris, but not in the variant angina pectoris. Drugs such as propranolol, esmolol, and sotalol are used as antiarrhythmics. Drugs like propranolol can be used in various arrhythmias like in paroxysmal supraventricular tachycardia, atrial fibrillation, etc. They are used in myocardial infarction for secondary prophylaxis. This means after an attack of myocardial infarction, when you give beta blockers to those patients, there will be decrease in chances of recurrence of myocardial infarction. So that's actually beneficial. They are also known to cause myocardial salvage during evolution of myocardial infarction. So if you know the pathogenesis of myocardial infarction, there will be development of infarct in the myocardium during myocardial infarction. If you administer beta blockers to the patients who are having myocardial infarction, there are chances that the infarcts do not grow much in size. So there will be comparatively smaller infarct compared to not treating with beta blockers, which can lead to larger infarcts. They can be used in congestive cardiac failure, but be careful that non-selective beta blockers can precipitate congestive cardiac failure and make it even worse for the patient. So, cardioselective beta blockers can be used for this purpose, and you should be quite careful when treating these patients with beta blockers, as there can be worsening of the symptoms in some cases. Beta blockers can also be used in dissecting aortic aneurysm. In this case, they decrease the cardiac contractility and the aortic pulsations, and by doing so, they decrease the chances of rupture of the aneurysm. They can also be used in pheochromocytoma. But if you're going to use beta blockers in pheochromocytoma, don't forget to add some alpha blocker also along with beta blockers in the treatment of pheochromocytoma, because in pheochromocytoma there will be an increase of excess amounts of catecholamines in the blood. So that they'll be having alpha actions as well as beta actions. So you have to block both alpha receptors as well as beta receptors. In thyrotoxicosis and thyroid storm, there will be various sympathetic manifestations. These manifestations include various symptoms like palpitations. These manifestations can be blocked by propranolol and mainly propranolol. Propranolol is actually preferred drug for um, these conditions. So, in addition to that, propranolol also blocks the conversion of T4 thyroid hormone to T3 thyroid hormone. So, this further is a beneficial effect. Propranolol is a very commonly used drug for treatment of migraine on a long-term basis. In addition to that, beta blockers like propranolol is being commonly used for treatment of anxiety. For example, if a person has to give a public speech in a stage in front of so many people, if he feels anxious, he can take a drug. He can take a single dose of propranolol and he can feel better. But on a long-term basis of anxiety, beta blockers are usually not preferred because of the associated side effects, and better alternatives, which are better anti-anxiety drugs, are actually available for this purpose. They are also known to control essential tremors, which means there'll be in this condition there'll be involuntary tremors, especially in the hands, making the routine activities of a patient difficult. But these drugs cannot control the tremors associated with Parkinson's disease. Adverse effects of beta blockers. Beta blockers, especially the non-selective beta blockers like propranolol, can precipitate congestive cardiac failure. That's why I mentioned earlier that cardioselective beta blockers or a few other drugs are actually used in congestive cardiac failure, and that too you should be very cautious while treating these patients with beta blockers. They can cause severe bradycardia in sick sinus syndrome. They can precipitate an asthma attack, especially because of blocking the beta 2 receptors present in the bronchi, leading to severe bronchoconstriction. They can exacerbate the variant angina. They can cause impaired carbohydrate tolerance. They increase the low density lipoprotein levels, triglyceride levels, but they decrease the high density lipoprotein levels in the blood. They're known to cause rebound hypertension, worsening of angina, or even death if you're gonna suddenly stop giving these drugs. Especially this side effect is found in drugs like propranolol. Now, if you're gonna treat a patient with propranolol on a long-term basis, make sure that if you want to stop giving this drug for this patient, you have to stop it down slowly by tapering the dose slowly. If you suddenly stop giving propranolol to a patient who's on a long-term treatment with propranolol, you'll have rebound hypertension, or if the patient had angina already, there'll be worsening of angina, and there can even be death of the patient due to sudden withdrawal. There can also be other adverse effects like tiredness and reduced exercise capacity. Now, tiredness is maybe because of decreased vascular perfusion to the muscles, and it can also be the result of uh, crossing the blood-brain barrier, and this can be a central nervous system side effect. Reduced exercise capacity is mainly because of decrease in glycogenolysis in the liver, muscles, etc. So after exercise, there'll be inadequate supply of energy to the skeletal muscles. So there'll be reduced exercise capacity. There'll be cold extremities. There can be worsening of already existing peripheral vascular diseases. There can be gastrointestinal symptoms. There can be lack of drive, motivation, lack of motivation. There can be nightmares. There can be forgetfulness and rarely hallucinations. These central nervous system side effects, such as lack of drive, nightmares, forgetfulness, hallucinations, are morely seen in drugs which are lipophilic, which has got the lipophilic pharmacokinetic property like propranolol, because these drugs can penetrate the blood-brain barrier. But this action, these adverse effects are very rare in the drugs which are not lipophilic or which are lipid insoluble. So this is the need to remember the pharmacokinetic property of these drugs. Beta blockers are known to cause sexual distress in males, especially for the males who are in the reproductive age group, by causing erectile dysfunction. So if you're going to treat a male patient who's in the reproductive age group, make sure that the patient is explained about this side effect, and you should be very cautious while treating a male in the reproductive age group with a beta blocker, because sexual distress is a very common complaint by these patients. Now, a brief description about labetalol, which is a non-selective beta blocker which has additional alpha blocking property. So it can block alpha receptor as well as beta receptors. Labetalol blocks alpha 1 receptor, beta 1 receptor, and beta 2 receptor. In addition to that, it also has weak beta 2 agonist activity. Now, the weak beta 2 agonist activity is not in significant amounts to carry out significant pharmacological actions in the body. They are known to cause fall in blood pressure, so they can be used in hypertension. The side effects of these drugs are commonly postural hypotension and failure of ejaculation. Carvedilol is another non-selective beta blocker which has additional alpha blocking property. In addition to all the other features of a non-selective beta blocker, carvedilol has antioxidant property, and it is found to be cardioprotective if you're going to if you're going to give this drug to a patient with congestive cardiac failure. So now let's talk about some important drug interactions. There will be masking of warning signs of hypoglycemia when you give beta blockers to diabetic patients who are on hypoglycemic drugs or even insulin. So what is this actually is that if a patient who's diabetic, let's say is on insulin, when a person who's diabetic is on insulin, takes insulin and forgets to take food, what will happen is that there will be hypoglycemia. So once hypoglycemia develops in these patients, they'll have some warning signs like giddiness, palpitations, etc. So that the patient will be aware of the condition, and they'll take some measures to help themselves, like they'll take some sugar or food, and that can improve the hypoglycemic symptoms. But when these kind of patients are treated with beta blockers, there'll be masking of these warning signs like giddiness, palpitation, etc. Because these warning signs are mainly mediated by sympathetic stimulation. When this sympathetic stimulation is blocked by beta receptors, there will be masking of these warning signs of hypoglycemia, and that the patient will be unaware that he is going through hypoglycemia. When alpha agonists are given along with beta blockers for any reason, they can cause a massive rise in blood pressure. This is very simple to understand. Let's consider a normal person who's not on any drug, okay? So that person will be having some of alpha receptor activity as well as beta receptor activity. Now, if you give beta blocker for this patient, what happens is there'll be no beta receptor activity, but there'll be alpha receptor activation, which is going on undisturbed. Now, if you further give an alpha agonist, it's going to add up to the action of the already present alpha receptors, but there will be unopposed beta action, unopposed alpha action, because we have already blocked the beta receptors with beta blockers in this patient. So there will be excess of alpha activation, leading to a massive rise in blood pressure. So this is another important drug interaction. When non-steroidal anti-inflammatory drugs like indomethacin are given along with beta blockers, they are found to decrease the antihypertensive effect of beta blockers. These are some of the significant interactions of various drugs with beta blockers. If you like this video and if you want me to make more videos in the future, make sure to donate me on www.patreon.com/medvidsmadesimple. Just visit this site and click on Become a Patreon, and if you donate any amount starting from $5, you can gain early access to all my videos, so that you can watch all my videos 2 days before the rest of everyone. If you guys want me to explain any topic in this video or on any other topic, make sure to comment below, and I'll be happy to explain about that in my blog page, and I'll get back to you as soon as possible. If you like this video, don't forget to like this video, share this video to your friends, and comment below. Most importantly, hit the subscribe button so that I'll make more videos in the future. Thanks for watching. I'll see you in my next video.